This is why it's so important. This is why it is so important that we focus on people with intellectual disabilities to make sure we're not missing something related to their health and may need help to swallow safely. There are some folks who are just not able to tell us that they're having difficulty, or we notice something different that's going on with their health, that it may be that they just need assistance in this area. More information and data we want to share with you. There are many individuals that have no report of eating, drinking, or swallowing difficulties prior to going to the hospital or from folks they live with. But yet, it can be identified when certain questions are asked at a visit. And then at that point, it's reported that, oh yeah, he does cough during meals, or he does seem to swallow hard. He's kind of always done that. Those are things that we sit there and we go, well, is that really typical of most people that we are allowing that to continue? Those dependent on others for oral feeding have a highest risk of chronic lung disease. So the individual needs to be fed by someone. The feeder needs to make sure that that person has swallowed the food in their mouth. They're looking at the person to make sure that they've swallowed. They're making sure that that individual's mouth is already clear and that they've seen them swallow. They've seen the swallow. So they're not distracted by something going on around them. They're really watching that person one-on-one while feeding them, giving their full attention so that they know they've safely swallowed what they've already had in their mouth. So many times, you need to be able to see in their mouth. So it's difficult if you're standing over someone and trying to feed them from above. You have to make sure that what you've already given them is already clear. Risk factors for dysphagia increases as severity of cognitive impairment increases in profound ID. We have folks that they're not able to tell us, oh, I like mashed potatoes. I'd rather have the meat right now. They're not able to tell us, I'm ready for the next bite. But you might be able to watch to see they're not opening their lips yet. They're turning their head and pursing their lips away from you because they're not ready for the next bite. So they're communicating in various ways. And the feeder needs to really be cognizant of what they're seeing and what the individual is doing. 15% of individuals with severe ID require support of all eating-related activities. And a study that was done in 2012 found that of those 15% that said, I need help while eating, a third reported that they did not receive such assistance. Their food was not cut up properly. Their food was not given to them in small bites. Maybe their liquid was not thickened as it should have been to the proper viscosity. So these individuals are counting on someone else to follow the guidelines, to follow the recommendations, and they can't do it themselves, so they need others to do it for them. Comorbidities that may complicate dysphagia. So a lot of health-related with individuals that we see. Psychiatric, behavioral issues. Someone might be eating very fast, eating large bites, food cramming. These are all things that we see that if we could provide strategies to individuals and give them an opportunity to swallow safely and avoid those potential risks. Medical conditions, we definitely see poor health with folks. They are maybe malnutritioned, they're not getting proper hydration. Folks are dehydrated, they're not offered enough to drink throughout the day. We may see folks who are not eating proper meals. They're eating a lot of processed food. So their health is poor. They may just have, like we said earlier, they have a diagnosis of cancer. They have a diagnosis of GERD. So all of these factors complicate their system. Poor oral health and bacteria in the mouth can certainly cause difficulty for an individual. Communication issues is really something that we're seeing more and more as folks are needing services in and out of the hospital, for example. So receptive communication impacts the person's ability to understand and to be able to follow directions. So an individual has to be able to do certain things to help themselves, right? So for some folks that we serve, it's just not able to do that. They're not a good candidate, possibly, for typical speech pathology treatments. They can't comply with a direction. Maybe they can do a one-step direction, but to be able to say, take a small bite, then take a sip after you drink and swallow, they can't do that. Don't take big bites. The individual may say, I know, I won't do it, and then they take a really large bite. They're not able to comply and understand directions that may be given to them to help them slow down, to help them have a healthier meal, those kinds of things. And expressive communication issues impact the ability for eating, drinking, and swallowing as well. So the individual is not able to tell us, I'm ready for the next bite. They're not able to say it. They feel like maybe something could be stuck in the back of their throat, but they can't tell us that they don't want anything else to eat. They could not. They could just say, I don't like the food, but they're not able to express that. So we often see that folks are released from a hospital or a skilled nursing facility, and they're not provided that support when they come out because there really isn't a lot of rehabilitation that's going on with that individual. We're trying to keep them as safe as possible, and the therapists that would come out to the homes, they're going to do a variety of techniques. They're going to try to get the individual to learn strategies, and they really need that support from others to help them to continue to be safe while eating and drinking. So continuing on with some of the prevalence of dysphagia that's according to ASHA, and this is really across many areas of diagnoses. So this is folks with various diseases, diagnoses, cerebral palsy, someone who have a stroke. These are percentages of folks that may have dysphagia or are at risk for swallowing disorders. The biggest is that there are people that also have a diagnosis and have an intellectual disability. So on the one part of this where it says intellectual disability, 3 to 8%. So we have folks that, yes, they are at risk for dysphagia, and they may also have Parkinson's. They may also have a traumatic brain injury as well. They have GERD. They have had a stroke. So their risk is increased for dysphagia in their lives. They are I can say more prone to potential eating and drinking problems, and therefore is something that we feel here at Summit DD. We're looking at those folks to make sure that, if they need services, we can help provide services to them. We're going to continue on with the presentation. I don't know if there's any questions right now in the chat before we continue. I don't know. I don't see anything. So Patty Hauserman is going to continue with her portion of the presentation.
Good afternoon, everybody. We're going to talk about the possible complications of dysphagia. The obvious one being that a person would choke or they have an airway blockage. This can happen with something very small. It could be due to a lot of reasons. Maybe they have a stricture in their esophagus. Maybe they took too big of a bite. They didn't properly prepare it. Perhaps it's way outside of what their dietary texture could be. We've all had episodes within our lifetime, whether we were distracted, we're eating too quickly, we take too big of a bite, we're talking, someone says something funny, we start to laugh, and we get that choking sensation. Another complication is an upper respiratory illness. And we're really talking about someone with dysphagia, the potential of having chronic respiratory episodes. Research is finding more and more that you can aspirate but not end up with a pneumonia. For years we thought, if they aspirate, then they're clearly going to get a pneumonia at some point. Well, that may or may not be true. What really complicates someone's susceptibility to pneumonia is underlying health concerns. Are they malnourished? Do they have cancer? Do they have GERD? Various things like that. It is a risk factor if someone aspirates that they may get a pneumonia, but it is not a surefire conclusion that just because someone aspirates that they will get a pneumonia, especially if that person is young and healthy and very mobile. What we really see is an increase in the aspiration pneumonia when someone is ill, when they're in the hospital, when they're bedbound, when they do not move around very much, if they're intubated, if they have a trach. All of those sorts of things just add to the potential of them getting an aspiration pneumonia. Weight loss. If you have a fear of eating because you're going to choke, or you've had some trauma around eating, chances are that's not going to be an enjoyable activity for you. So you may avoid it. If someone has difficulty maintaining breath support while they're swallowing, because when you swallow, you stop breathing. And if that little episode of you stopping to breathe fatigues you and makes you lose your breath, you're going to stop eating. In order to live, we need to breathe. And our instinct is we're going to do whatever it takes to continue to breathe. And if that means I stop eating because I'm tired, I'm losing my breath, that may result in a weight loss. Dehydration. This is so important for all of us, for our overall good health and just our well-being and our comfort. I look around every day and I see people with their big buckets of water and drinking them all day long, me included. But do we offer the same level of hydration to those we serve? We don't. Oftentimes we see in someone's lunchbox a little Huggy, which is probably 6, maybe 8 ounces, or they have a juice box, again, maybe 10 ounces. So we really need to be cognizant of the fact that we are serving adults and that they need more hydration that they're getting. This is also extremely important with the elderly. So poor nutrition and malnutrition. So there's been a study done that the elderly in long-term care facilities, 23 to 85% of those elderly individuals in a long-term care facility are suffering from protein malnutrition. 23 to 85%. Now, is there a correlation between the elderly in a long-term care facility and those we serve? I don't know. I can only imagine, because more research is being done with the elderly and people with dementia than is currently being done for folks that have an intellectual disability. It does make me wonder, though, those folks that are being served in a congregate setting, are they more likely to also have a protein deficiency? And why is that? Why is there potential that that could be the case? Protein and meats tend to be more fibrous. They're more difficult to chew. They're tough. They're dry. We've all had a piece of steak or a piece of chicken that just was cooked a bit too much, and you just seem to keep chewing and chewing and chewing and chewing. And it just never seems to really get masticated or get processed. If we were to swallow that, the potential for choking is pretty great. Another thing could be is that meat and those proteins tend to be more expensive. So if you're on a limited budget, you may go for options that are less expensive. Pastas, processed food. If you're not eating meat and you're hungry, you're going to fill up on other things. Carbohydrates tend to be easier to chew. You have your pastas, you have your breads, even though some of the breads really become like glue in your mouth. But that might be why that is the case, that people are limited in their protein intake, and therefore that becomes a nutritional concern. Constipation. If you do not have a well-balanced, well-rounded diet with adequate hydration, say you're maybe not as mobile as other people, you may be in a wheelchair, you may not have the opportunity to stand or weight bear and let gravity be your friend and move things along. Constipation is a real concern and a real issue for the folks that we serve. If you are constipated, and not to be insensitive, but to be real, if you are not eliminating the food that you put in your body, why would you want to put more in your body? You're uncomfortable. So people may avoid eating just because they're constipated and they just feel full and uncomfortable. Patrice touched on esophagitis with the GERD, and that's really just the acid of your stomach bubbling up and eating away at your esophagus. And it's like a burn, and it can be uncomfortable. And if that continues, it can go into something called Barrett's esophagus, which is a great concern because it is a precancerous condition. So many folks have GERD, and we kind of just take it for granted. Oh, I have GERD. Oh, yeah, I have reflux. Oh, I get heartburn. Many of us say that, but it can become quite serious. So it really should be addressed. People sometimes have an inability to combat infections. They have other things going on. They're not feeling well. They've just gotten out of the hospital. So that's something that really needs to be looked at as well. If they have dysphagia, is there an underlying reason? It's not just that they're older, or that they have cerebral palsy. Maybe they have something else going on, and we really do need to get to the bottom of it and address all of their health concerns. Urinary tract infections. Again, hydration will help alleviate the number of urinary tract infections. We also deal with a lot of folks that are brief dependent and that are not terribly mobile. So we really do need to be cognizant that this is a frequent thing that we see with the folks that we serve. The other thing with UTIs is, the person might start to feel better and pink up, and then they finish their antibiotics, and in 3 days, you're noticing changes again, that change in mental status, or that they're just feeling puny. And it might be that the infection was not cleared up with that first round of antibiotics. So we really have to be cognizant of that as well. And there are some psychosocial complications with dysphagia. My food looks differently. Food is important. Food is love. Food is socialization. It's parties. I don't want to go out if I need to have pureed food. Oh, that looks like baby food. Your food might look different, but it should still be enjoyable and it should still taste good. I always say that, if you need to puree someone's food, if it went into that machine tasting good, it's going to come out tasting good. The texture, yes, will be different, but it will taste as good as when it went in. Now, conversely, we don't have any magic machines that if it tasted pretty bad going in, it's going to taste worse coming out. And then the ultimate complication of dysphagia is death. Something to note is that, again, the research with people that have dementia, folks that have dementia, and we have people that we serve that also have a diagnosis of dementia. If they have dementia and they have dysphagia, they are 2 times more likely to die from aspiration pneumonia. So the mortality rates from respiratory disease in the folks that we serve is 3 times higher. It kind of makes sense because, like Patrice mentioned, it's thought that the folks that we serve are 3 times more likely to have dysphagia and aspirate. So it stands to reason that they would be 3 times more likely to die from respiratory disease than the general population. And in 2015, Perez found that bronchopneumonia was the leading cause of death in people with intellectual disabilities. And the more profound the intellectual disabilities and additional disabilities that they may have, they were more prone. So risk factors that are predictive of choking, cramming food, eating fast. These are all things that do not surprise us. Physiological factors of premature loss of the food over the base of the tongue. So as we're chewing, especially if we take large bites, we're chewing, and while we're chewing, some of that food is moving back in our mouth and over the base of our tongue. And it may go over the base of the tongue much sooner than we're ready to initiate a swallow. So that can cause issues. And of those 85% in the study that were identified as high risk, 85% of them had a near fatal choking incident. That's pretty astounding, 85%. So Patrice mentioned earlier some statistics about aspiration, and Langmore, who is very well known in our industry for dysphagia, in 1998, found a list of predictive factors. And these are the top 3. The number 1, and by far, and this has been repeated in many, many studies following this one in 1998, that those dependent on others to feed them are 20 times more likely to aspirate. 20 times. That's very significant. So what does that mean? We want to encourage independence as much as we can. Feeding yourself is one of the last skills that we lose. And why is that? Because, and if you think back to maybe grandparents or parents or loved ones or friends that you've known that have gone through an extended illness, and before they pass, one of the last things they do is they stop eating because they're that ill that they can no longer do that for themselves. Now, we have folks that have never been able to feed themselves independently, but those that can, we should allow them to do as much as they can. If it's they take 3 bites by themselves, let them take those 3 bites and then assist them. If it's they can drink independently, if they have a special cup or a special straw, then let's get them what they need so they can be more independent. Sometimes, and talking about the end of life issue, just something I thought of last night was some folks are very hesitant about having someone get a tube for tube feeding. And I understand it. I understand that eating is important, drinking is important, but we often hear from family members, I don't want them to have a tube because then they're going to die. Because they've had a family member who had quite an extensive illness. And one of the last things they remember is that they did get a feeding tube and then they did die, and they blame the feeding tube. That may or may not be the case. They may have gotten a tube because they had a cancer. Chances are they didn't die because they got the tube. They died from the cancer, but that they correlate that. So there's a lot of hesitation about tubes. Is a tube the perfect means of eating and drinking? No. Does it have its own set of complications? Yes. Can you aspirate with a tube feed? Absolutely. It's just some of the things that we've heard over the years. So number 2 on the list, so number 1 was dependent on feeding. Number 2 is dependent on others for oral care. I know that if you've sat in on any of our presentations, we harp on the oral care, and it really is just one of the most important things that we could possibly pass along. You know, some of the folks that we serve, they're difficult. They are difficult to provide that care for. They're resistant to having something put in their mouth. Maybe you can desensitize them over the years, but it is important to try to give consistent and complete oral care for folks. The bacteria in our mouths have bacteria anyway, but if we don't provide oral care, within 48 hours, the bacteria becomes gram-negative, which means that it can cause infections and often can be resistant to bacteria or to antibiotics. So we really need to be cognizant and do our best to give the best oral care that the person will allow us to do. And then number 3 was missing teeth. So it's difficult to chew if you're missing teeth. It's difficult to bite food off if you're missing your front teeth. It's difficult to know if the person is in pain, if other teeth are bothering them. Why are their teeth missing? Is it because of poor oral care? Are they losing bone density? Do they have gingivitis? These are all things that we should question and try and address. And I realize that it's sometimes difficult to get some of our folks in for oral care and into the dentist, and the waiting list, if they need sedation, is really crazy. So I hope that in the future that this will become more on the radar and we can provide better service for the folks that we serve in this regard. So some of the language that you may see in an ISP, maybe you're an SSA and you've inherited an ISP and you might see some of this language. if you do see something along these lines, I would start asking some questions. Hey, they require supervision while eating so he doesn't choke. Or food should be cut up into small pieces so he doesn't choke. Oh, that's how he eats. He always does that. He always coughs after a meal. He pounds his chest, or, a couple of times a week he eats and he goes and throws up in the bathroom. I would start digging deeper, because there likely is something, whether it's something more going on, whether it's dysphagia or something else, but I would ask more questions. So something that is extremely important, and Patrice and I really count on the observations of DSPs and family members, because they're with the person and they know them better than she and I can. Like I always tell the DSPs, you know Joe better than I know him. I know swallowing, so let's work together to provide the best service we can for him. So the DSPs and the family members, they're the ones that are going to go to the grocery store. They're going to plan the meals. They're going to fix the meals. They're going to make sure that they get their medications. They're going to make sure that they get something to drink. If there's a change, they're going to be the ones that notice that, because they're with them all the time and they're assisting them with mealtime. And hopefully they're going to raise the flag and say, listen, this is different. Joe is coughing and he didn't used to do that, or he's stopping his meal with food on his plate and he always wanted seconds. These are all things that are different, and they're going to be the ones that not only interpret what the change is, but how severe it is. And then again, raise the red flag. And they're going to be the ones, because of, being the ones that are raising that concern, the need and the type of intervention. Am I going to mention it to my group home manager? Am I going to mention it to the nurse? Am I going to mention it at his next doctor's appointment? So their role is very important in initiating any sort of assessment or care that individual might need. And again, the DSP, they're going to assist and ensure that that person is getting good and consistent oral care. Sometimes things happen over a long period of time, and because of that, we don't raise the red flag. But when someone else comes in, say a new set of eyes, maybe a new DSP, and they're like, boy, Sally really, her eyes water and she coughs when she goes back to her bedroom after a meal. And, maybe a more seasoned staff will be like, yeah, that she does do that. She's always done that. Maybe she's done that for a long time, but it's not normal. So a new set of eyes or a different way of looking at things can really help raise a concern and help an individual. So research has showed that direct support professionals, those people that are helping with meals, whether it's in a day program or in a home, feel rushed during mealtime. Patrice and I have gone out to day programs and we've been told, they have a half an hour for lunch, and that's that. We have other people we have to help, and we understand time constraints. But if an individual needs more time, we'll ask, well, can they go down to the lunch area maybe 15 minutes early with other people that need a little bit more time to eat? We need to provide time for people to eat safely. Worldwide, there is a recognition that people with eating, drinking, and swallowing issues don't always, the red flag is not always raised. And the one consistent time that it is raised is upon death. And this is a global issue worldwide. It is not just within the United States. The one thing that research has shown is that globally, it just isn't raised as a concern until the person dies. That is certainly something that we all want to avoid. The other thing is that recognizing if someone's having difficulty eating really can change their quality of life. Maybe the person avoids hamburgers and they love hamburgers, but if they were prepared just a little bit differently, they could enjoy those, and they could enjoy a barbecue with their family. Those things are important. So we realize that there are barriers to receiving dysphagia services. We are very well aware here in Summit County that we are fortunate that the board has supported the services that Patrice and I provide, so that we can help the people of Summit County with their eating, drinking, and swallowing needs. A barrier to receiving those services is if you don't have access as readily as we do here in Summit County. Identifying the need, it's especially difficult with individuals with complex needs or communication difficulties. They're not saying, oh, my chest hurts, or it's something stuck, or they have behavior complications after a meal. Well, it might be because they don't feel well, or something stuck, or it upsets their stomach, or it exacerbates their GERD. Sometimes, folks don't know who to tell. They don't know who understands the swallowing. Is it a nurse? Is it the group home manager? Are there expert staff available that do know things about swallowing, that they can answer the staff's questions or give them advice on what to do? And once that's identified, are there people available that say they go and have a modified barium swallow study and they say, yep, this person needs to be on soft and bite size and moderately thick liquids. Is there anybody that can explain to them what that is versus just leaving with the discharge papers and, yep, here you go, good luck? So we need to find ways to help if those people aren't readily available. Raise the issue to group home staff managers. Raise the issue to the nurse. Raise the issue to the primary care physician. Would it be helpful to appoint a staff person that can raise the issue to the next person? Whether that's the group home manager or a program director or something like that. The care system is taxed. We appreciate that. Staff shortages, trying to hire people that will stick with the job, who are educated, who know how to cook a well-balanced meal, who know how to identify a well-balanced meal, who are willing to learn. I've trained folks that they're like, I have no experience helping people with their meals or helping to feed someone. And my response usually is, good. You don't have any bad habits. If you're willing to learn, we will figure this out. Our primary concern is the health and safety of those that we serve. And certainly eating, drinking, and swallowing is right up there. So what can we do? Let's be the change. Let's start with things that we probably can do better at. Let's start with consistent and complete oral care. Increased oral bacteria decreases a person's immunity to fight disease. We all microaspirate, probably during our sleep usually, but the average person microaspirates 17 times a day. So if your oral care is good and your health is good, chances are you'll never be the wiser. But if your oral care is not good and you have some underlying medical issues, say heart disease, or maybe you're diabetic, then it might really become a problem. So let's start with implementing consistent and complete oral care, or at least better care. Let's just start to strive and be better. And we realize that sometimes it is difficult to do with some folks. But if there's a protocol in place, the frequency, when is it going to happen? How's it going to happen? We have the equipment on hand to help those folks. And encourage and maximize a person's independence with oral intake and oral care. Again, we want to limit how dependent they are. The more they can do independently, the better off we're going to be. Mastication. If they can handle chewing more solid foods, that's going to help with control of the bacteria as well. When Patrice and I were talking about this, she goes, so there really was something to that apple a day keeps the doctor away. It does help remove some of that bacteria from the teeth. And maintaining the independence, the self-feeding as much as they can, the drinking. Nutritious meals, offering nutritious and well-balanced meals. Let's be honest, some folks don't cook for themselves, and yet we want them to cook for the folks that we serve. So we're going to have to offer some help there. I often say folks that are on altered diets or have special nutritional needs, a crock pot's probably going to be your best friend. You're going to have the protein, you're going to have the vegetables, you'll have the gravy, and the meats tend to be softer. So anyone can throw things in a pot. We often wish we had more access to a registered dietitian or a nutritionist. Maybe in the future that'll be the case, but until then, we just do the best that we can, and include the individuals with planning their meals. What do you like? Oh, I like chicken. Well, you can serve chicken about 10,000 different ways. So involve them in preparation of the meals. If they're on an altered diet, let them operate the machine. Let them help cut it up. Ensure access to adequate hydration throughout the day. I realize that there's a lot to get done in a day when you're serving a number of folks, but I often recommend, offer a drive-by. A drive-by drink is you're walking by the person, say, hey, Susie, would you like a drink? And offer them a drink. You do that a number of times a day, you've gotten another 8 or 10 ounces of fluid into that person. Every little bit helps. And help make mealtime an enjoyable social event. Sit down, family style dining. Meals are meant to be a social event. I'd rather a person be distracted by a funny story about your dog or your son's baseball game than watching reruns of Law and Order on the television and not having that interaction. The social interaction of a conversation just naturally slows down a meal. So I would like to open it up for any questions that anyone might have.
So we have several questions in the Q&A, if you can both see those and respond.
Yeah, I see a few. Yes, the first one I see has to do with the individuals with Down syndrome. And yes, it will continue likely as they age to have difficulties with swallowing disorders. We often see that individuals with Down syndrome, and research has shown that they may tend to get dementia earlier in their lifetime than typical developing adults. So this is something that we certainly watch for as we see folks in our program. Yes.
The other thing with folks that have Down syndrome is that they do have some anatomical differences that you tend to see. Oftentimes a larger tongue. They also are more prone to esophageal strictures, which is the narrowing of the esophagus, which makes it more difficult for particles of food to go down. So oftentimes they need to have that dilated, just like you would with an angiogram with a balloon. It's as simple as that. And that usually really helps alleviate some of those issues.
So the other question came up is, do you have any resources for SSAs or DSPs? I'm not sure if I'm asking the right question, but during meetings or assessments, how could we boost our trainings and monitor more closely and report concerns to the doctor and the team.
I think anything that raises a red flag to you. So say, for instance, we cut his food up so he doesn't choke. Well, why do you do that? When did that start? Did something happen? Did he choke? What did he choke on? Has this been raised to the doctor? Things like that. And if that's a good place to start, is often with the doctor. And sometimes, the folks don't know the answer to that. Oftentimes the family will say, oh yeah, they had a cookie swallow back when he was 3. Well, he's 27, and things are still happening. Maybe you can start there. That is one of the gold standard assessments. If you can get a doctor to order that, you can always work off of that. An SLP can always work off of that as well. If you have more specific questions, just send one of us an email and we'll happily send you a list of things and clarify that question more readily.
There's Patty and I both might tag team this one. Folks asking about tube feedings and with challenging behaviors while the person is I'm thinking while they're being fed and they're touching or yanking and creating infections with the tube. So one of the things that I've said for years is this individual is eating. And so are they eating at the table? The tube feeding is eating. They are getting their nutrition at that time. Are they sitting up at the table? Are they given something to do in front of them to keep them active and keep their hands busy? There are certain things that you can put over the tubes to keep it so that the individual can't get at it. But is it a social time with others while they may be eating orally? This person is eating by tube. It's still their meal time. Patty, do you have any thoughts on that? That was my first thought.
I would also consult with nurses. I mean, we deal with tube feeding oftentimes as a result that they are not safe to have anything by mouth, or they receive tube feedings for their primary hydration and nutrition, and then they just have pleasure foods, and we help with that. But I really would consult with your nursing staff or the physicians, because they are much better versed in the tube feedings than I certainly am. The next question is about processing the foods. So they're the proper texture, but the look mimics the food that they're supposed to be. They do have molds. And there are companies that provide pureed meals that put their food in molds. So it does look like the food that is pureed. So peas look like peas, but when you put a spoon into it, it's pureed. They do offer those molds for sale. They're a bit expensive, but if you're a big agency or, folks tend to eat similar foods, you can make a big batch and freeze them, but they do have molds that mimic how the food looks.
I don't know that someone would be able to actually pick up the food as if taking a bite out of a hamburger. If it's something like a pureed or minced and moist food, that gets quite tricky. It's more of using the spoon, but at least it gives them a visual of the food and really telling the person what they're eating. I'm really strongly advocate for shared living providers and congregate settings to put on the containers what is in that. So while someone is eating, you can say, this is chicken. You're having chicken Alfredo today for dinner, and you're having it again for lunch today, whatever it might be, just so that you were able to have that conversation about what is the food that they're eating, and we don't play a guessing game.
Sometimes you can ask the person too. Hamburgers are really popular with the folks that we serve.
Yeah.
And I'll ask them, hey, do you like sloppy joes? Oh, I like sloppy joes. Okay, well, how about we make your hamburger? And it'll probably look like a sloppy joe, but it'll taste like a hamburger because we'll add the ketchup and we'll add the mustard that you enjoy. And if they're soft and bite-sized, we'll put it back and we'll cut it up really small. And they're like, oh, okay. So, just being honest with the person. And honestly, the longer I do this, I used to be, oh, you can't eat this, you can't eat that. Now I'm like, okay, let's work together and let's find a way that you can still enjoy the food. It might look different, but it's going to taste the same. So the next question is about diverticulitis. And so that's a pouch anywhere along the swallowing mechanism. And while it may not affect the swallow directly, what it may affect is that if food is getting into that pocket and later on after the meal, the person might bring something back up in their mouth, or there might be something in their mouth once they go to bed, or they aspirate when they lie down because that food comes out of the pouch. So it may not be directly due to dysphagia, but it can have an effect on their overall health. Patrice, do you have anything to add to that?
Just that recently an individual on my caseload was found to have diverticula because she did continue to cough after eating. And she said she felt fine, but we wanted to go ahead and figure it out. And that's what was discovered, is that she did have that diagnosis. I see someone did put up information about the ITSE resources and standardized guidelines for different levels. And that is something we're going to talk about in our next session next month in September. Do you offer education on differing diets, mechanical versus pureed, etc., or any recommended good resources? So that resource for the IDDSI, the International Dysphagia Diet, is a global initiative that has been adapted by ASHA and here at Summit DD, and that is the type of texture and descriptions we use for describing food, and we provide that to direct service providers and all providers of folks on our caseload, so that they can have a better description of what the texture is and what they should and should not be providing individuals to continue to eat safely. Is there anything else? I don't see any others, do you?
I think that was the last one. So I want to thank both of you, and we will see you again on September 12th for the final session. I think you're going to be talking about some different types of diets and textures, correct, on that session?
Correct.
Yes.
So that last question is a perfect setup for third session.
Yes, it is. Thank you for your time and attention, everyone.
Thank you.
Thank you, Willie.